Hello and welcome to TCT South Asia 2024. Um, we're honored to be part of the conference, and I'm Dr.Arun Kalyanasundaram from ProMed Hospital. This is Dr. Anand Manjunath, um, our very seasoned associate interventional cardiologist, who's kind of like my right hand. This is a 44-year-old female patient with diabetes who had an anterior MI about 4 years ago that was taken care of percutaneously, and at that time she had some disease on her RCA, but she was kind of lost to follow-up, lots of economic reasons and personal stuff, etc. So basically it was a no-show until about recently when she presented back, and on angiogram we'll just kind of see the dual angiography here. We had bifemoral access. You see there's a high-grade ramus that's diseased. The LAD stent itself is fairly patent. There's also disease in the circumflex, and you have disease in the RCA. I've gone bifemoral, given that I wanted backup. I was thinking ADR, could have gone radial femoral, but again, women many times, there's an issue of spasm, etc. So I just went bifemoral. I can kind of talk about that. Interestingly, on dual angiography, it just appears that it's actually not that long. It's only about 20 millimeters. So initially, I thought this would be a great ADR case because truthfully, I thought it's a longer RCA CTO, but sometimes it really underscores the importance of doing bilateral angiograms just so that we understand the importance of the whole thing. Can I have a microcatheter 135, Nazir? Open, please. Thank you. Just while we're waiting, it is important to note that you always place a safety wire in the donor vessel in the event that something happens. We kind of have left it a little bit disengaged because 7 French, there's a little bit of dampening anytime we actually engage the vessel. And something that's got good torque response. So can you make an argument for 1? Sure. Can you make an argument for 3? Sure. It depends on what you think is appropriate. And I really don't want to wire this. I'm hoping it goes subintimal, but I'm just kidding. Whatever works. Okay. Looks like we've made enough progress. Okay, we're dancing with the vessel. Okay. Just remember with your Conquest Pro 12, it can go places, right? Just because it goes, don't follow it with a microcatheter. Confirm position before you do, okay? I may be in that branch. I don't know. I might be in free space. I really have no idea. But I went somewhere. So as a safety measure, what you don't do is follow it up with your microcatheter. Nope, somewhere. So I'm just going to try to stick in another place and see if I can get it down. Okay. Small, actually test point. Retrograde danda full. Okay. So I just did a completely different trajectory, pulling the wire back. Pulling the microcatheter back. This looks more promising. Okay, good. I'm not still sure about the distal most tip, but seems like we're in a better area. Okay. Once again, looks like we are just deviating at the very tip, but overall, much more in line. Okay. Give me another retrograde test, please. Okay. Yeah. Inject. Nope. Okay. So you guys just saw that, right? I was at the distal cap, I pushed, it just prolapsed. Okay. Okay. Give me a JR4. Let's just do it. Okay. Yep, we're in. Good, let's go. Okay. Much better guide. Okay. Give me the Gaia second again, please. Give me the talker, please. Okay. Retrograde test. Store fluoro. Okay. Okay, very close. As you see, this guide is good, but doesn't give me backup. Okay. Okay, made some progress. Okay, good. So always check in 2 projections, make sure you're good. Looks like we are okay. I'm gonna disengage the left because I don't like that pressure. Okay, good. And I just push it. So if you're true, many times it'll just go. If it's subintimal, it tends to buckle. I'm pretty sure I'm true. Okay, we're good. So I have a lot of respect, I think I've said this on stage before, for operators in our part of the world, because we do work many times with with a lot of constraints and limited resources. So yeah, I mean, still got to get the job done safely. So all in all, not so bad. I think we use 1 microcatheter, 2 wires, and 3, including the workhorse ones. Actually 4, including the safety wire. Okay, good. Inflate. 12. Deflate. Deflate. This was a AW strategy. I'm okay. I'm just gonna take a pick. Anti-grade. Normally I don't, but I think this is fine here. Okay, good. Let's go. I think my plan is just to stent those areas that I need to. Oh, that's the Synergy XD extra deliverable. Delivered like a charm. Okay, good. I think that's good, guys. Hello? Good. Deflate. Yeah, I will. Okay. Deflate. Perfect. Okay, good. I think you're fine. Okay, good. Give me the tubo balloon, please. Okay. I'm just gonna do probe at the distal vessel. Looks like there is some disease. Yeah. Yeah. Just into the PD, man. Okay, good. Fast off it, guys. Let's go. Okay. Just gonna do a long balloon angioplasty. See how it is. Plus minus DCB. You can also put a 2 to 5 DCB. Like, doing CTOs is part of the job. I think, the bigger message. I mean, this patient. I was personally invested in when they'd come initially, just because of her age and the whole socioeconomic status. Spent a lot of time, effort, emotionally getting to like support them through it, and we still, couldn't. For whatever reason, it's kind of a complex situation. Never followed up until there were actually issues. So the reason I'm even saying this is, I think, we should make every effort to ensure that patients know the importance of good medical therapy and follow up after we, deal with the CTOs. It's not over once you open up the blockage. Boys, DCB, A and A. Looks really good. Trying to. Okay, go. So I just went from the distal edge of the stent to this. Okay. Go. Okay. Okay, we're gonna leave it up for about a minute. Very happy with the results. There's no obvious dissection that I see. I'm gonna pull the wire back, leave it here, take one more pick. Okay, we're done. So we're gonna fix the ramus off camera. Thanks for watching. So just in conclusion, young female patient diabetic. You are welcome. I'm just wrapping up. Yeah, yeah. So young female patient, a diabetic who has had a CTO in the right and ensuring 4 years since her last PCI. Um, our plan was to do ADR. We went bifermal access, started with microcatheter workhorse wire, got to the proximal cap, penetrated initially with the Gaia second next, went further down, tried with the CP12 unsuccessfully at the distal cap, and I finally was in good position and I pushed, I backed up my entire system. So just went with the JR4, not my usual favorite guide, but um, got the job done because I was pretty sure I could pull it off with this. Um, and actually used the guy second next again, and this time crossed true to true. Got the microcatheter beyond, exchange for a workhorse wire, took out the microcatheter with a trapid balloon, prepared the vessel bed, stented the proximal part, one stent distally, again prepare the bed, DCB, and a pretty gratifying result in general for DCB. Do a 1-to-1 NC balloon as prep, and kind of go from there. All right, thanks from the team. Thanks to the whole team for having supported us through. Thanks.